Yes, and I will go live in just 1 second. All right, I'm getting a notice that we're unable to do live streaming right now, so we will have to upload it later, so feel free to start.
Okay, good morning, everyone. It is November 28th, 2023. It is 8:05 a.m. I'm going to call the Board of Health meeting to order. My name is Deanna Diamore, Director of Health for the Norwalk Health Department, City of Norwalk. First the attendees, we have Ken Lomeem, who's a board member, and Terry Quell, who's a board member. And we also have staff members Brian Weeks and Daniela Fignon. We are waiting for an additional board member to join. So can we move the approval of the minutes to later in the meeting to when she joins? Is that okay? So we have a quorum?
Yes.
Okay. All right, so then we're just going to jump in and get to the second item on the agenda, which is the Norwalk Community Health and Wellbeing Profile. So as you know, we partner with Norwalk Hospital and other community partners to conduct a community health assessment periodically. And we've been doing this for years. And so for the latest iteration, Nuvance has been, leading the assessment for our region. And we've been, now that we have Brian on board, we're looking to see, for the hospitals, they do it on a regional basis, and we're trying to see, how can we supplement that information and get more local Norwalk information in there as well. And so we're sort of building this process as we go. And so Brian has been working really hard on putting together a dashboard and a profile for us that has local data for Norwalk, and that kind of compiles all different sources and puts it in one place. And so we wanted to show it to you today. It's a work in progress, so definitely want your input as we look to improve it. But Brian's done an incredible job. He's already debuted it locally. We have a Norwalk GIS day with some of the internal city departments, and he's also shared it with some state partners as well during their GIS day. And so before we officially launch it, we wanted to show it to the Board of Health to get your thoughts. So I'm going to pass it on to Brian, and Brian, please share any other preliminary information that you want to share too.
Hey, good morning, everybody. And thank you, Deanna. I think you actually did a pretty good job covering it. So the other point I'll just emphasize with this is it is very much a living website. So it's going to be appended to, updated, adjusted accordingly to all our needs to really kind of just provide a comprehensive overview of what's going on with the city. And in turn our residents. So it really, it could be informing us in terms of just other kind of activities we could do. Helps with, applying for certain grants or proposals or directing that work as well as community partners can use that data for the same work too, and then also know what they're kind of doing or dealing with relative to their work too. So without further ado, here, I'll just jump right into it. And so what you
Brian, I'm sorry to interrupt you. I just, for 1 second, I see that Dr. Carpiet has joined. Daniela, can you move over into panelists? So I just want to let everyone know Dr. Carpiet joined at 8:08 a.m. and we have a quorum now. Thanks, Brian.
He's been promoted.
Alrighty. So yeah, jumping back into it. So this is the initial loadout of the City of Norwalk, Connecticut Community Health and Wellbeing Profile. The future website address is going to be the norwalkct.gov/CHOV, which is usually typically the community health assessment, because it is essentially falling under that umbrella and it's going that comprehensive nature. So it's kind of, we're kind of using it somewhat interchangeably at the moment, but right now it is the community health and wellbeing profile. And so again, it's just like a little welcome and intro page, and then it goes straight into kind of the major resources as Deanna kind of outlined that kind of contribute to our current community health assessment. And so that is the Fairfield County Community Wellbeing Index, which builds off the Community Wellbeing Survey from Data Haven. And then there's also Nuvance Health and Norwalk Hospital, the 2022 Community Health Needs Assessment Report. And then along with that, the recent Data Haven Norwalk equity profiles, and so the most recent ones for 2023. And so all these resources are here in one place, so it makes it really easy for us, as well as for any other city departments, community partners, any residents that are interested in looking at this information. It's all in one place, so it's easy to access. So they don't have to dig around. They may not be aware of these things, and so it makes it much easier from an awareness and just just information standpoint for everybody. And then this leads into kind of the three kind of major data sources that we're currently using, but we're going to keep adding to. And so this is number one, the CDC Behavioral Risk Factor Surveillance System, or BRFIS, as I'll call it, /places, which is a kind of a build off of that, just to make local data available and assessments relative to what the BRFIS is. Along with that, the Data Haven Community Wellbeing Survey, or CWS, and then the CDC ATSDR Social Vulnerability Index, or SVI. So what is the CDC BRFIS, along with places? So the BRFIS is essentially a telephonic survey that's administered nationally. And so it's done in every state, and more or less it's asking, a multitude of questions in regards to just, health status, health outcomes, other kind of health behaviors, especially risky behaviors, things of that nature, things of that, essentially just kind of getting a better understanding in terms of what people's status is in terms of their health, as well as other prevention measures, like physical activity, things that they may be doing. And so more or less, as you can see here, I built a dashboard on this, and it's depicting the crude prevalences. So essentially, it's the proportion relative to the geographic area we're looking at. So as you'll see, the data that's presented is for the city itself, and then also for the census tract or neighborhood for the city of Norwalk. And so we have kind of a nice sub-granular, breakdown geographically for the city itself, kind of understanding what the situation is by neighborhood. So this gives us a lot better direction and better understanding when you look at these different conditions and measures that are outputted here. So as you can see here, say if we wanted to look, the first loadout or initial loadout is for any disability. So anybody experiencing disability, this is for 18 years plus. And this is for data from 2021. You can see currently how the loadout is relative to the neighborhoods for Norwalk. And as you can see here, the darker the coloring indicates a higher crude prevalence or proportion. And as you can see here, you have kind of Woodward, you got Springwood, and you got Golden Hill that have the highest proportion. And so Golden Hill at 28.1%. So somebody indicating that they have some sort of disability relative to this survey that's been administered. And again, as a reminder, this survey is administered to adults only, so 18 plus years of age. But then relative to the city, so the overall city situation is 21.4% for any disability. But anyways, somebody can kind of go through here, select whatever they may be interested in, better understanding relative to the health situation for the city. Obviously a big one is cardiovascular health, and you can see all the different kind of measures associated with that. So you can look at the crude prevalence relative to heart disease, and then you can see how, interestingly, it's a decent proportion of that, but in terms of the neighborhoods, in terms of them kind of being similar to each other. So the highest is Broad River at 5.5%, with the city at 4.6%. And again, what this implies, and so there's details here that kind of just delineate that a little bit more clearly. It's coronary heart disease among adults aged 18 plus years. And then you could also see the other things kind of associated with that as well. Somebody's if they're, somebody that's diagnosed with high blood pressure, if they're taking medication to control it, 18 plus years of age. And then you can see that proportion as well. And you can see how it presents very similarly to the coronary heart disease situation. And then you could also look at what else ties into it, right? Physical health status. And so you can see physical health not good for the, greater than essentially 2 weeks. Greater than or equal to 2 weeks for 18 plus years of age. And you can see again, the three kind of, and this is kind of a theme and something that kind of helps direct us is, with Woodward, Springwood, and Golden Hill being kind of the higher proportion of that. But then also, again, you can look at it from a physical activity standpoint. And then again, somewhat similar theme relative to the city based on the neighborhoods. And again, that definition is no leisure time physical activity among, again, adults. But you can just keep breaking it down however which way you want, and this just gives us really good understanding what's going on. What you might see here on the left-hand side, bottom left, is also the crude prevalences if there's additional years of data over the years. And so you can then see the trends, and this is for the city, and then over here is for by neighborhood. And then you can click this little arrow here, and then you can kind of expand it, because especially when you look at it by neighborhood, we obviously have a large number of neighborhoods, and so it's a lot easier to look at it this way. And then you kind of, select whichever neighborhood you're trying to look at, and you can kind of get a better idea what's going on. So, and then just hover over it, and it will also just indicate what's going on. So anyways, that's the, I think I already kind of put a little too much time into that, so I'll move a little bit quicker here. Number two, in terms of data sets, is the Data Haven Community Wellbeing Survey. As I mentioned, This is something that's administered every 3 years. It leads the Community Well-Being Index, which is essentially an assessment of that. But this survey is another telephonic survey administered to adults in Connecticut, and it's, obviously Norwalk being a part of that. And this is, a bunch of questions, hundreds of questions that are compiled and determined by an advisory council that we're also a part of, which includes up to 300 organizations. So you're talking about other nonprofits, academic institutions, other locality municipalities, and different departments relative to that, including health departments. So it's a really great resource, really kind of local to Connecticut, which is really great. And so this is just, essentially what's really great about this is, although it doesn't do the sub-geographical kind of assessments relative to neighborhood, it does give us a really good idea relative to demographics. So especially when you look at it from sex, age group, race, and ethnicity, highest level of education attained, income level, and if children are living in the household. And so if I scroll down, you'll see kind of the dashboard here. It's a big one. And so this is looking at the most recent data set for 2021, and then the different questions associated with it. And so we'll be highlighting different questions because there's a lot, but different ones that kind of are very relevant and very important when you factor into health and to well-being, and to obviously stress factors too that may contribute and influence somebody's health. And so right now, the first question that's loading out, as you'll see here, is how will you rate your overall health? And then you can see the breakdown by the response options. So excellent, very good, good, fair, poor, don't know, refused, and then also by the demographic. And so there's two different ways to visualize this because we want to just make sure people can kind of interpret this well, and get all the information they can out of this that they want. And so you can see that the options here are presented as a kind of like a cluster bar chart, or also as a table. And then you can kind of see relative to Connecticut, Norwalk, again, as I mentioned, sex, age group, race and ethnicity, education attained, income, and then children in the household. And so you can kind of just better understand relative to those responses. And so as you can see here, there's a greater proportion of individuals indicating that their overall health, is very good and good, but then you can kind of see where the outliers are relative to certain, demographic items. And so especially in terms of age group, those that are 35 to 49 indicate, a little bit higher proportion than say, compared to the other demographics looking here, evaluated here. And then you go select by the different questions that you have options for. So, again, if you're looking at for substance use, if somebody feels safe walking around their neighborhood at night, available, affordable, high quality fruits and vegetables, access to a car when needed. So then you can just select these different options, and then you can see the answer responses relative to that. And then on the right-hand side, there's also some considerations when interpreting this that one must factor in, or be cautious with interpreting. So, just as a heads up, because sometimes with the sample sizes, when doing these telephonic surveys, sometimes you don't get a large enough denominator, so it makes it a little bit, unreliable in terms of interpretation, but it still gives you a rough idea what's going on. So that is the Community Wellbeing Survey. And then finally, we have the CDC ATSDR Social Vulnerability Index, so SVI. This is a really interesting measure. So again, this is, the CDC and the Agency for Toxic Substances and Disease Registry, ATSDR. And this is really done relative to, if you have some sort of calamity or a natural disaster or disease outbreak or some other, very concerning event that occurs, it really looks at it again from the neighborhood aspect or census tract and trying to evaluate where there may be greater vulnerability in terms of impacts relative to this calamity, as well as the response, maybe if you're evacuating individuals where you need to make greater prioritization relative to that, and also just the ability to, return and then, rebuild or whatever it might be, where more resources maybe needed to be allocated just to get things back to normal. And so it's really great. It's in terms of really kind of getting a better assessment going and understanding of things. It's using census tract data, so from the American Community Survey, along with 16 social factors that it factors in. So as you can see here on the right-hand side, so we basically recreated this visual from the CDC. So excuse the color palettes because I'm not always the most color inclined individual in terms of when doing these visuals. But when you look at this, there's 4 different themes: socioeconomic status, so it's looking at below 150% poverty level, unemployed, housing cost burden, no high school diploma, no health insurance. Number 2, household characteristics: age 65 and older, age 17 and younger, civilian with a disability, single parent households, English language proficiency. 3 is racial and ethnic minority status, so more or less anybody that's non-Hispanic, white, or Caucasian. And then theme 4, housing type and transportation, multi-unit structures, mobile homes, crowding, no vehicle group quarters. And then all 4 of these themes then inform the overall social vulnerability index. And so this is then the visual that I developed here relative to this. And so what this is doing, because you could look at it from a nationwide perspective or a statewide perspective, I did it relative to the nationwide because it gives us really a good way to benchmark ourselves against other census tracts or essentially neighborhoods relative to most of these other towns and cities throughout the whole country. And so this is, you'll see it's presented as percentiles, and the way to interpret that is essentially like a ranking. So when say for example here Springwood for 2020, and this is the overall nationwide SVI percentile rank, 85.69% implies that Springwood is greater in vulnerability, in overall vulnerability, than essentially almost 86% of other census tracts in the country, which is not great. You want to have a lower percentile. And so this is something that kind of informs us and gives us a really much better idea what's going on relative to these neighborhoods, especially the vulnerability. And so this is again looking at overall, and so you can see on the left-hand side a map visual. It's doing it based upon some recommendations from the CDC to do it by quartiles, and so 4 different intervals. And so you can see here kind of where it sits in terms of the different neighborhoods. So when you look at it from a quartile perspective, you can see how Hospital Hill, South Norwalk, East Norwalk, and Springwood are the greatest in terms of vulnerability, but it's also followed by other neighborhoods too in the city. And so then you can look at it also from a trends perspective for the 5 most recent assessments for this, and then you can see then Springwood, East Norwalk, South Norwalk, Hospital Hill, and Woodward definitely are like some of the major concerns here relative to that being in a higher percentile proportion too. So you can break it down by theme too. So if you wanted to focus on socioeconomic status, then you can click this. Then you can kind of see the breakdown relative to the different neighborhoods for that. The quartile mapping, and then for racial and ethnic minority status, housing type and transportation, household characteristics. So it's just a really good idea. Again, I apologize for the color palette here. I'm trying to just find the best way to delineate these things so it's very easy to understand and work with and interpret the themes. So but that's overall kind of the 3 major data sets. So just to summarize really quick, we have the BRFIS, as you saw here. So it's a great telephonic survey administered nationally. It gives us a very good idea subgeographically, especially relative to these different measures. You have the Community Wellbeing Survey, which is another great Connecticut-centric telephonic survey that looks at it relative, especially a lot of different demographic information. And then you have the SVI from the CDC and ATSDR, and that gives us a really good idea based on census data what the situation is for the city. And this will be continually updated as new assessments come out because the CDC currently has it on a every 2-year basis that they release this. And then finally, just a little thing to tie it all together, and this will be updated as well. This is showing 211, which is a really great resource just to direct individuals, should they be needing, any sort of basic needs, housing needs, access to healthy foods, things of that nature, access to other resources that they may not be aware of. They can call 211 for Connecticut, and it directs them to those resources, or they can use this website that, gets linked out to when they click on the graphic here or the link here. And then finally, this is just a special thanks, and this is something that will be appended to as well, just relative to these primary resources and the community partners that helped inform this initial part of the community health and well-being profile for Norwalk. This is special thanks to Newvance Health, Data Haven, the State Health Department, the CDC as well. And so that's just a quick overview of this, but as you can see, it's still in its infancy. It's still very much in a more simpler format. It's going to keep getting appended to, and there's going to be a lot happening here. And it's going to direct you to a lot of different other resources and information too. So that is kind of just the overview of the Norwalk Community Health and Wellbeing profile. I'll defer to Deanna, and I think we're just interested if you guys had any sort of questions or any comments.
Exactly. That's it.
First, I love the overall graphic with the green. It's beautiful. Could you talk a little bit more, Brian, about how the data is collected? Did you say it's all telephone survey?
Yeah, so these the CDC, BRFIS, as well as the community wellbeing surveys, yes, they're conducted by phone. Yes. And so it's done by evaluating the phone numbers of, just nationwide. And, essentially some of them are also randomly generated based upon, certain prefixes that indicate it's in a certain region or part of a state or, a town or a city. And so that's the kind of the way that's done. Correct.
It's kind of interesting because a lot of people don't pick up their phone anymore. I mean, I still have a landline, and if I don't know the number, I don't even pick it up. So I don't know that I would ever be included in a survey.
No, correct.
So it's interesting, to think about who's picking up the phone to give the answers.
No, it's an excellent point, and this is kind of the nature and limitation of any survey that's administered, right?
Yeah.
So whether it's by telephone, whether it's in person, whether it's by mail, which is the census data is also influenced strongly by, just kind of that, obviously there's individuals that go door to door, but then that's limited by what geographic area they kind of prioritize. And then also mail, which also has its own issues. And so, yeah, there's always going to be a bias or some sort of influence there. And so when interpreting this information, one must factor it in. But there are also other statistical methods that are applied so that it should be able to be generalized to the population, this information. So when the CDC does it and Data Haven too, it should give a good representation of what the situation is, and then also be able to be benchmarked to prior iterations of it so you can then look at the trends fairly. So yeah, but there's always going to be a catch to everything. But you take that into account when you're doing these assessments, but at the same time, it gives you a rough idea what's going on, and instead of obviously having nothing. And so these are all great resources, and they're from reputable resources too, which is really great. So again, the CDC, Data Haven, and ATSDR.
Great, thank you.
Brian, who's our target audience for this?
So everyone, anything Norwalk related, really. So not only is it just something that we're going to use for ourselves, but at the same time, this will also be applied to other departments. In terms of, as Deanna alluded to, I presented to the city, to town hall, and then more or less, there was a lot of interest from other departments too. So they're going to use it for grants, and just kind of comparing different metrics or measures relative to maybe substance use, for impaired driving, for other kind of, situations in terms of physical activity, feeling safe at night, adequate transportation and the road conditions, things of that nature. So there's different departments that can kind of utilize this to inform any sort of, funding opportunities they may be pursuing, as well as just kind of keeping a watch on their metrics and seeing how they're performing over the years too, from an evaluation standpoint. Then along with that, community partners. So I also presented it at the Connecticut GIS Day, and so there's other towns and cities looking to mimic this or mirror this, along with even the air quality, index that the hub, air quality hub for the city that I presented on a little while back, especially when we were having the situation back in May and June. And so they're all looking to kind of adopt it for their own localities and municipalities and their own regions. Even the COGS, shared some interest as well. So the Council of Governments, relative to different regions too. It covers a whole gamut. Academic partners would be interested in this because I'm certain there's data resources, especially like say Data Haven, that certain institutions may not be familiar with. And so this is also kind of just compiling all that information for them, and then residents that may be just interested to see what's going on. So it's really for anything Norwalk centric. Anybody that's looking for Norwalk data, here's the place to be. Here's everything. Here's especially these really reputable data resources that are very comprehensive. But then there's also going to be very specific data resources that we'll be posting and sharing there as well. Sorry, that was a really long answer. But yeah, thanks.
Is it something that would lend itself to inquiries, that setting up some type of educational forum where people can put in questions and we can get back to them, or even other municipalities that want to kind of shape their futures around this kind of information about providing those kinds of data elements to them?
Yeah, exactly. It's almost like democratizing data, but it's really empowering the community so we can kind of all work in concert and be aware of all these different informations and data sources that exist. So, and work with it. The stuff exists. It's all over the place. It's all different websites, just like when we did the air quality monitoring hub. EPA and Air Now had really great resources, but it was just on a bunch of different tabs, different web links, and things like that. So we just want to compile it, make it very easy for everybody to access, and set the standard in some ways too. Because I think that's the only fair way to do it relative to our community and who we're working with.
A lot of information.
All right, thanks.
Thank you, Brian. So we will keep you all updated, as this gets further developed, and then when we officially launch it. But thank you so much, Brian, for that overview and for the great questions. So the next item on the agenda is respiratory illness update. So I'll let Brian jump into that, and then we'll do the approval of the minutes after that. So back to you, Brian.
All right, thanks. And I'll try to go quick because I know I'm kind of in verbose mode today. So with that said, we'll jump right into the new COVID hospital admissions relative to U.S. counties. So this is a CDC data source. So we want to keep tabs on things because it's after Thanksgiving now. And as we kind of typically understand, especially relative to COVID, it is a pivot point relative to, just the presentation of especially hospitalizations related to it. So this is, again, the metric. Right now, this data is updated every Friday. So, and there's also just a couple weeks delay relative to this data. So we have to factor this in. So this is data up to November 18th. When you look at it for the Northeast, you can see we're still in the green, which is good. You can see parts of, New York, Vermont, and New Hampshire, that have moderate activity, as you can see right here, especially more like upstate New York. But, as you can see, relative to COVID, the bigger impacts seem to be the mid-Atlantic region. You got the Midwest getting hit, in different areas in terms of the counties, as well as even the South, Southwest too. And so it's actually really interesting how it's presenting right now. This is a little bit different, actually, typically than what we see at this point in time in the year, because usually the Northeast is starting to kind of really pick up. So kind of good news in some ways, but again, we have to factor in the 2-week delay. So the impacts of Thanksgiving are not really visualized here yet. So we still have a week or two to really start seeing that start to present in that data, but it's still interesting situation that we have relative to COVID. So it's actually not as I wouldn't say crazy, but as active as it was, say, in prior years that we were looking at it relative to COVID hospitalizations. And so, again, as a reminder, there's just a lot of different subvariants that are circulating relative to COVID as well right now in terms of the CDC surveillance for that, and it just has chosen to refresh on me. But HV1 is the largest proportion of that at almost 32%, or almost a third. And then you got EG5, 13.1%. And so more or less, there's a lot of different names, a lot of different subvariants. And the story is, again, that once it presents in the United States, it's presenting everywhere, as I kind of continually mention. And you can see here relative to that regional surveillance, same story of presenting. But there's a lot. And so, those also contribute to just different variables of how things present. Along with that, we have the wastewater monitoring. So keep in mind now, we're only at 1 sample per week. This is looking at it for Fairfield County in Connecticut, as you can see right here. And as you can see, we had a much higher peak, back in like late September. We're not at that level of activity right now, as I kind of was alluding to, but, still our activity is picking up a little bit, even indicated by this data set. And so, again, we're flying with a little bit less data and information just because it's a sample once a week as opposed to twice a week as it used to be, because it's currently the contract that happened with Verily. So it's transitioning from BioBot to Verily, which is like almost a Google company. So we're looking forward to once they have those assessments relative to these geographic areas. But right now, BioBot's still doing a very good job with that, and they're still getting one specimen that they assess for. Looking from the State Health Department surveillance, just really quickly again. This is looking at case counts relative to influenza. And as you can see here, more or less the story or takeaway is that it's picking up relative to flu. And you can also see how type A and type B flu are present in Connecticut at the moment. But, predominantly it is a type A flu situation right now. RSV, same story. RSV picking up quite a bit. And that's actually the next, in the second visual from now, you'll see kind of an indication of that. Relative to COVID, you can see how it's kind of holding steady more or less. So you could almost make an argument that's plateaued at the moment relative to the state of Connecticut. But again, hitting home the points that influenza and RSV are really picking up. This is national trends. And as you can see here, if you look at it from the combined perspective, respiratory illness is picking up. But when you look at it from a COVID perspective, again, it's holding kind of that plateau nationally. But influenza and RSV you do see picking up as well. So that's also something indicated nationally as well. And this is RSV tests, positive tests on the right-hand side here, PCR detections, the purple line. So as you can see here, again, this is a reminder where we were back in the prior season of the prior year. That was kind of the really abnormally historically high RSV activity. And again, that was related to different reasons. But again, more so the fact that we did such a great job of prevention measures and lockdowns and things like that. We had a very susceptible population once, things kind of loosened up. and increase that opportunity for, increased exposure to and manifestation of the illness. But we still have kind of the same story playing out again, which is the very interesting thing here and kind of concerning thing relative to RSV. You can see how we're almost, it's getting close to almost halfway of that activity from the prior season. So RSV is definitely the one that's kind of the biggest concern here at the moment relative to its rapid growth and spread. And so that's the other point I want to hit home. Relative to Norwalk data and information, the largest proportion that's impacted is less than 10 years of age. So it's mostly in the pediatric population, which is typically how you see the presentation for RSV. But what's not great is that, it can then in turn expose others in the household, just like we had the concern relative to COVID and flu. Same story here. And so it can also impact, vulnerable individuals that may be in the household, especially those that are 65 plus. And I think it's just really important to kind of factor in too. And so then it creates some more opportunity for transmission further from there. And so it's really important to consider and take into account. And then also when you look at it for the weekly influenza surveillance report, this is influenza-like illness. And so this is another good indication where we're at in the country. So this is, again, looking at it more from the flu perspective, as we kind of, seen this report in the past, by state. And you can see the South and the Southeast is the most impacted right now with essentially high influenza-like illness activity. You can see even in the West Coast. But again, it's creeping its way up on the Eastern Seaboard, so the Mid-Atlantic region presenting at moderate, and then also even Connecticut, kind of on the border between low and moderate activity. But then good old New York City kind of being also more or less in the high activity as well. And so that's going to be influencing and creating opportunities for further transmission too. So this is just another good indicator of kind of where things are at. So more or less to summarize, COVID's kind of holding steady, which is a good thing. It's actually a little bit lower than we typically see at this time of the year. But again, the data sources are also on a latency time period. So we have to kind of wait to see how that plays out in the next couple of weeks. But RSV is, again, abnormally high, but also kind of mirroring the prior season, which is not good because that, obviously resulted in a lot of hospitalizations, especially children's hospitals being overwhelmed. And then also influenza is also still on the rise and still making its way up the seaboard, as you can see here, and especially with all the travel that occurred with Thanksgiving. This is going to be something that we're going to probably see play out over the weeks and as we anticipate with the season. So a lot of different things in terms of how the scenario could play out. Not a great story for, again, flu and RSV. COVID is yet to be seen, but so far it's a better story for that at the moment. So we'll keep you updated on that, but just wanted to share that. Thanks.
Thank you, Brian. Does anybody have any questions? All right. I'd like to move back to approval of the minutes. So does anybody have a motion for approving the October 24th, 2023 meeting minutes?
So moved.
Any seconds?
Second.
Janet, second. Thank you. Any discussion on the minutes? All those in favor say aye.
Aye.
All right, that's it. They passed. Thank you. All right, back to the other updates. So immunization updates. So the staff has been really busy coordinating flu clinics. So just wanted to share some numbers. As of yesterday, we had administered 631 flu vaccines this season. 486 are out of private inventory and 145 were out of the Vaccine for Children's doses. So staff has been really busy doing some work sites, some Thursday afternoon clinics, some larger scale community events. And so want to let everyone know that the flu clinics will continue while supplies last. So we on our website, if you go to norwalkct.gov/flu, you'll see some, like, all of the upcoming dates, but typically it's Thursday afternoons from 1 to 3 p.m. here at the health department. We've also been administering some COVID-19 vaccines as well. And so we've administered 45 of those with the new booster. So those are updates for immunizations. So great work with the team. Continue to be really busy with clinics, especially childhood immunization. We're continuing to book those. So I really can't thank the staff enough for all that they're doing, getting our community members immunized. And we're gonna move on to performance management. So Daniela has put together a presentation, so I'm gonna pass it on to her to give an update.
Hey, good morning, everyone. Just give me a moment to share my screen. All right. All right, great. So this morning we were talking quickly about performance management, taking a look at how we did during the fiscal year 22-23, and just generally talking about some of the highlights of the year, some of the challenges that we faced, and how we are going to move forward with performance management in the coming year, or the fiscal year that we're in right now. So just a quick overview of what we'll be talking about. I'm going to give a quick refresher on what performance management is. I'm going to give a little bit of an overview of how to understand the status key. I'm going to provide a little overview of the annual analysis and that process, highlights successes and challenges, and then some recommendations. So as you are all probably pretty familiar with at this point, performance management is the practice of actively using performance data to improve the public's health through the strategic use of performance standards and measures, progress reports, and ongoing quality improvement. Really what this is a cyclical process where we are continuously evaluating our performance on a quarterly basis. We collect data. And we create narratives or write narratives to explain where that data is coming from or how we achieved that data. This is an example of our performance management dashboard, which is the system that we have in place. We use these dashboards to track all of our performance management measures. So just going to back up. We have one dashboard per division. So we have 6 divisions and an office of the director. So that's what you're seeing right now is the office of the director's mock dashboard. There's a goal at the top of each dashboard that describes the goal of the office of the division. And then there are objectives that you can see right over here that describe or to kind of distill that goal into further specified objectives. Down in the actual dashboard, what you see is a domain for each of the objectives. And under each domain, there are key performance measures. So you can see that the performance measures are right here. And for each quarter, we have a target that we have set up for how to measure whether or not we've met the objective for that quarter. There's also an annual status bar. So at the end of the year, we tally up, whether or not people or the department has gotten to achieve the goals that it set out for itself. And we also have a little status bar over here where folks can easily just view whether or not the objective was met, whether it had a little bit of work to do. And then there's also a performance narrative section where supervisors or the person who's in charge of the dashboard. So here you can see that is me for the office of the director, but it's a different person for each of the different divisions. But each quarter they're able to go into this performance narrative area and just sort of describe some of the highlights, challenges, some of the barriers possibly to not reaching 100% of their goal or not reaching the numbers that they were looking for. Alternatively, there may be an excess in the status. So potentially we've exceeded our goals, and we can describe the highlights and all of the successes that we've had in that performance narrative area. So as I mentioned, we do track the status of each of these measures, and we use a color coding symbol to make it really easy for people to just go into the dashboard and quickly see or get a sense of how that division is doing in terms of performance. So dark green means that we have met 95% of the target or greater. Light green is between 85 and 95% of the target. Yellow is between 70 and 85%. Red is 70% of the target or less, and gray means that it was not measured within the quarter or was not applicable for some other reason. So I'm going to dive right into the annual analysis and just looking at how we did in 22-23. So I am happy to report that we measured a total of 95 measures, which I think is a bunch and is really quite a large number for a department of less than 40 staff. So as you can see, it's broken out across division. So last year we did not have the Office of the Director, which is why there are only 6 divisions in place. And for each of those divisions, there is a a quick, easy way to reference how many measures were in the red, how many were in the yellow, light green, dark green, or in the gray. So for this past fiscal year, we can see that 58% of our measures were completely 100% totally met, which is awesome. We had over 60% of our measures that were, mostly met. And then we get into the 70-ish% range when we add in those, partially met measures. We did have a couple of measures that, as you can see in the 22% area, were not met at that 70% or greater threshold. And I wanted to just pause and let Deanna just talk for a quick moment about sort of why some of those measures may not have been met, like within the full scope of what they were outlined to be.
So I'd like to echo what Aniela said, 95 measures. Wow. Our staff is really ambitious. So wanting to do so much within a short time period of a year. And so sort of what Aniela is alluding to is, we did have some staffing transitions. We did have some vacancies. And so some of the goals that we had set for ourselves were really ambitious, and given all of like the changes, things were happening, movement, but sometimes something might have not been completed and it continued on to the next year. So one of the examples is the workforce development plan. And Aniela worked on that plan. She made a lot of edits to it with Megan's help. But then we said, all right, let's put a pause to finalizing that until we complete a core competencies assessment and until we finalize the strategic plan. And so there's some measures like that where activity was happening, progress was happening, but we didn't complete it to its fullest. So and I can also share more as Aniela goes through to provide more, more context, but just wanted to share that. Thanks, Aniela.
Thank you, Deanna. And yes, there's going to be an opportunity at the end when we're talking about more of the specific highlights, the successes and challenges for Deanna to really expand on what those challenges and successes were. So moving right along, when we took a look at the dashboards, the process for reviewing the dashboards was that I met with the supervisor for each division, and we both reviewed the metrics and narratives by quarter and year. We have a setup in our filing system where, we have somebody go in, the supervisor goes into a file, and they basically just describe or, flesh out the narratives for each of the measures that they were addressing in their dashboard for the year. It's really just expounding upon the Excel spreadsheet and putting it into more of like a Word format so it's easy to read. And so in that document, we have supervisors actually identify which measures were unhelpful to their division, have them identify successes and opportunities for improvement. And then they use these identifications to create next steps for continuing to pursue division goals. And what that looks like is reviewing and updating performance measures. So some of the performance measures may no longer be applicable. Some of them may need to be refined or tweaked so that the language, reflects the actual work that we're doing now. So like Deanna was mentioning, for example, the workforce development plan. The measure in the fiscal year 22-23 was to get it finalized and pushed out the door. And the measure for this year was tweaked a little bit to just the language was tweaked a little bit to reflect that we had done work in the previous year, but that we were going to continue working on it and to finalize it this year. And then the last step is really launching those dashboards. So we refine those dashboards for the upcoming fiscal year, like I said. And then over the course of the first quarter, we typically see folks looking at their data, working with their data, reviewing their measures and thinking, I think I just want to change this word, or I want to change, this measure from a number to a percentage to better reflect the data and for it to be a little bit more comprehensible right off the bat. So I'm going to jump into some of the successes. We had truly a really successful year. It was an honor to do this for my first year as a project coordinator and to see so many of the divisions, really all of the divisions have so much success. And even in the areas where there was just areas for improvement, I still saw a lot of successes. So I'm just going to dive right in with some of these. So we saw 100% of childhood immunization and tuberculosis patients were reminded of appointments between Q1 and Q3. And so that means to us that the front desk is really on top of making sure that patients are connected to the information that they need to make sure that they are accessing their services on time. We also had the best IEP rates in the state for both the Norwalk and Danbury catchment area. So I want to do a little shout out to Megan and Pam and Sarah from our IEP team. They have all done just really incredible things, making sure that our kids under 2 are vaccinated with all of their appropriate vaccinations. And then I know that Megan really is focused on COVID vaccinations. And so I just wanted to, shout out to her and, just really highlight that both Norwalk and Danbury catchment areas met full coverage COVID vaccination goals, which was incredible compared to the rest of the state. Contact tracing was also attempted for 100% of COVID cases. We felt very lucky to have 2 contact tracers on staff for the year. And chronic illnesses were also addressed in a really meaningful way. Our community health division held almost double the amount of chronic illness screening events than they had intended. And 88% of the screening clients that they met with that did not have insurance or a medical home were connected to available resources. So we're really seeing our team going out into the community, connecting with folks that need resources and making sure that those connections happen. For our emergency preparedness division, we created executive summaries for all of the department emergency plans so that staff members and anyone else can easily reference, the point and the purpose of the plan and also key contacts. And we had 28 new members join our ERT team. So yay to those, especially with a new ERT volunteer coordinator in place. We also had all of our housing inspections completed in a timely manner, and abatements for notices of violations were also addressed in a very timely manner. And then 2 of the, sort of internal processes or internal, programs that we worked on are the quality improvement, initiatives. So our work group was reinvigorated post-pandemic, and we were able to have 2 meetings. And so while we did not meet our goal of 4 meetings for the year, we did meet the goal of 2 meetings once that work group was reinvigorated. So we're able to meet the target for the last 2 quarters. And then 100% of our staff maintained required licensure and certification to continue delivering excellent service. So shout out to all of our sanitarians, our inspectors, our clinical staff, really everybody across the board for maintaining all of their needed licensures and certifications. There were, of course, some barriers that we experienced and some opportunities for improvement that were identified. So as Deanna mentioned, there were a number of transitions throughout the year in terms of staff. So for example, my role, Megan transitioned into the special projects manager role, and I transitioned from the public health program associate role into the project coordinator role. And that delayed some of the activities just because there was a little bit of learning curve, orientation to my new role. And, it just really kind of puts a pause on things. There was also the benefit of having, a fresh set of eyes on things. And so that means, revamping the approach that we take to things and potentially, moving things a little bit further down the timeline to make them, meet the new standards or the new ideas. So along those lines, I was not able to introduce I was not able to deliver the intro to QI training consistently to staff within 90 days of hire due to competing priorities and orientation overload. And so a little bit of that was on me. That's what I thought. And I was writing that into the narrative at first, and then sort of realized that actually folks would prefer to have a 6-month period where they can take or where they can engage in that training so that it's not too much information during their orientation right off the bat, and they are able to actually kind of digest it. Some other areas that we noticed could be improved. Some of our emergency preparedness trainings that we had planned were not delivered in a timely manner. And a lot of that really just comes down to planning. So, we've refined our dashboards in this year to reflect timing. The implementation of the FDA food code in our environmental health division really impacted our inspections of food establishments. So for almost the entire Q3, food establishment inspections were put on pause just so that our staff was able to get all the training that they needed to provide inspections in the way that they are now required to. Body care inspections also took a little bit of a hit this year, and just require a little bit of attention in terms of planning. We've also had a number of funding challenges that prevented some divisions, like our epidemiology division, from hiring staff in a timely manner or in the manner or in the time prescribed in the dashboard. Similarly, state reporting and delays around that prevents timely access to certain kinds of data, such as WIC data for our Women, Infants, and Children program. So we're not able to report on the dashboard on some of those measures in the time frame that we need to. We've also had a really big increase in the number of grants to the department, which requires a lot more attention and has also required a little bit of a balancing against other administrative responsibilities. And as we see changes in staffing, as we see changes in responsibilities, that can definitely impact some of our other measures and our just capacity to do work. And lastly, we have definitely realized we need some sort of a financial management system needed to, streamline data entry, reporting, and other activities to really just to free up time and generally improve accessibility, make it more palatable and digestible for folks across the board. And at this point, I'm going to let Deanna chime in.
Just wanted to add to Aniela's comment. We have a financial management system, but we need a new and improved one for sure. Thanks, Aniela.
Yeah, so really just we need a system, like a software system that's going to work for us. So in terms of revising dashboards, what we did is took a look at some of those barriers and opportunities and just change the dashboards a little bit, tweak them to reflect our new needs. So in the administration and office of the director dashboards, we actually split those into 2 separate dashboards. And we decided to offer introduction to quality improvement training on a more flexible basis, like I mentioned, within that 6-month time frame. We also asked our QI team that is working on the grants filing project to sort of revise their goals around that and to make it a little bit more, a little less vague. For our community health team, we decided to track the number of outreach activities conducted because we know they are out there all the time doing so much outreach. And so we really wanted to make sure that we are capturing that information. And we also wanted to track the number of health equity related trainings identified or provided to health department staff. And lastly, we increased the target for annual chronic illness screenings because we did so well last year. We thought that we should increase the goal. In our emergency preparedness division, we adjusted the timelines for our trainings so that we had a long enough planning period for us to be able to meet those goals. And we also decided that we were going to track the percentage of IRT members who are trained in the incident command system, which is the FEMA system that all of us kind of use as a framework for addressing emergency response. Our environmental health division decided to revise its body care inspection metrics to track numbers instead of percentages to better illustrate the data and to really keep them on top of achieving those numbers in a timely manner. And they also maintained a 100% food establishment inspection goal. So that's not actually a change, but it's with the understanding of the FDA food code impact. So the narratives are going to look a little different this year, right? The first quarter, there's still going to be a bit of a transition. Quarter 2, I'm sure there will still be a little bit of transition. So those narratives will reflect why the data goes in the way that it does and what numbers come up. In our epidemiology division, all of the domains were actually reorganized because it is a new division and really evolving. So Brian wanted to kind of reorganize that to reflect where the division is right now. And some of the things that he is now tracking is percentage of hepatitis C and STI initial case follow-ups, and also the number of VOC, which is one of the software systems we're using, or other software solutions or development or support that he is providing throughout the department as the program director of epidemiology and informatics. And then lastly, our preventable diseases division is going to be tracking the number of flu and U presentations delivered by IAP staff. That's a fun little thing where IAP staff go out and meet with kids, usually in preschool to elementary school, and do hand washing and a lot of communicable disease prevention education. So before I move on, I do want to pause again and just provide Deanna with an opportunity to give a little bit more of an explanation of sort of how the dashboards came to be the way they are with the movement that's happening in the department.
No, I just want to, thanks, Danielle, just reiterate, this really is all about quality improvement. And so that's what we see this as, yes, we want dashboards that are updated and reflect where we are as a department. So a lot of work and thought has been put into that by Daniela and all the supervisors, the whole team and their staff. But also really it's to drive quality improvement. And so really looking forward to, continue to use this system to drive our quality improvement projects and just to make our department, continuously better. So thank you, Aniela, for leading this for us.
Thank you, Deanna. And I think that kind of wraps it up. Our QI work group is going to be ready to assist with any potential projects identified in the system. And hopefully we'll be able to get a couple of QI projects off the ground and report on those to you guys soon. But otherwise, we are tracking the data and we'll fill you in when we have more information. So thank you all.
Thank you, Aniela. Does anybody have any questions for Aniela?
Not a question, but a comment. A tremendous amount of work that you can see from this dashboard. My only thought is that you guys are so ambitious. Like you have so many things that you're doing and so many things that you're tracking. I'm almost wondering if, you guys have been through so much work the last couple of years. I wonder if you should scale back a little bit. Because you don't want to, I feel like you guys are going to burn yourself out. You're working so hard and you have such high expectations.
I'd like to echo that a little bit, and just that I think you run into a potential for more failed, if you would, criteria, that you have too many things so you can't get to those. So it looks as though you failed at them, but they really didn't, you just ran out of gas. So I would hate to see all the good work that is done go to measure something that has a negative outcome.
Yeah, absolutely. And that makes a lot of sense. I think we've been trying to counter that a little bit with the narrative sections, where, we can explain why those barriers came up or explain why successes happened. But we definitely appreciated that there were a number of objectives or measures that we were not able to meet fully. And so we did try to refine our measures quite a bit, but note taken to try to scale back a little bit and perhaps think about how to make that a little bit more palatable for folks in the upcoming year.
I appreciate those comments and that feedback, Terry and Ken, so much, because it's really important too, because we are doing a lot. And so how do we maintain that and really focus on the things that, are most important that we need to focus on. And so thank you. Okay. I know it's 9:02, so I'll try to get through the other items quickly. So the Board of Health meeting schedule for 2024, we have to submit that soon to the mayor's office and city clerk. So I can send an email out to everybody, like just to poll them for their availability. I'll look at both morning and evening times and just to see about availability. Does that work? Unless anybody has any specific comments they want to share right now. All right, so I'll
Schedule works okay.
What was that, Terry?
The current schedule works okay for me. I don't know about other folks.
Okay.
Are we going to try and do another evening meeting or a couple of evening meetings or something?
We can. I know we've done that in the past and we still haven't gotten, great participation, but we certainly can.
Just a thought, because it's come up in the past.
Mm-hmm.
Yeah, I'm fine with the current schedule. Evenings are tough, but I can easily schedule the mornings around my work schedule.
Okay.
I'm okay with the current, what we have right now.
Okay. All right. Just a quick update for director's report. I wanted to share that it's we're in recognition of World AIDS Day on December 1st. We're our sexual health program is going to be holding additional walk-in clinics for rapid HIV testing. And so we'll be promoting that soon. But December 1st, we'll be having some hours in the afternoon, and then we're going to do it for several times throughout the month. So December 8th, December 15th, and December 29th, we'll be having some morning and afternoon hours for rapid HIV testing. So the purpose of the event is to honor the lives of those who have succumbed to HIV/AIDS, celebrate the advances that we've made in battling the disease, and provide opportunities for the community to join in the fight by getting tested and knowing their status. And so we're going to also be passing out additional educational materials during the clinics, and we'll link any positive cases to care and treatment. So I want to thank our team for that. And I will move on to public participation. And I think I see a hand up, Aniela. Diane Lauricella, can you please unmute yourself?
Yes.
And you have 3 minutes to speak. Good morning,
Sure.
Diane.
Good morning. And I was very happy to listen to many of the efforts and initiatives that the department is undertaking. I have not been on the call, Zoom call, for several months, not because I'm not interested in all the good things you're doing. It's because I had other priorities. But I'm looking forward to 2024, as I'm sure all of you are. So I wanted to approach the department in a different manner, especially with the onset of the holiday season. I wanted to thank the department. We did get a vaccine both for COVID and the flu. But as I was there, I saw some missed opportunities to help communicate in the preventable disease division more about how to prevent getting respiratory diseases and viruses. I know that the department put together a postcard on Spanish on one side and English on the other, and I think that's a good first step. But I think I have some ideas that I think will make it even more effective. And so, Deanne, I wanted to know if I could make an appointment sometime this week with whomever you feel I should, to see if there could be an update of this postcard to include a little more information about masking, which has been an ongoing concern of mine that wasn't addressed in this postcard. But I do think there are opportunities even between now and the end of the year to have pictures and different kinds of posters that the supermarkets could put up right at the beginning, the entrance of their places. I am sure they would cooperate. And also giving out masks or giving out hand sanitizers in those little bottles, giving out the COVID tests. I did get a box of self-testing. I also do think that, lastly, that, of course, nowhere to go but up. There's just a lot of additional opportunities to really reach out to more of the public in places where the public goes to get ready for their holiday meals. And I did go to every supermarket in the city, and there was nothing there about being preventive. I was one of the few people that had a mask on, but I just think that we could do a lot more in a very measured way. Nothing in your face, but just more helpful. And lastly, I just wanted to say the dashboard that Brian has put together is very interesting to me, being in the business, environmental health business. And I guess I would be very interested in seeing going forward how we can look at community diseases or issues coming up. And one such issue would be the asthma rates. The reason I decided to highlight that instead of some of the other things that I will introduce in the future is because today the governor announced that they will not be putting forth this year the clean car and clean truck legislation that the Connecticut legislature approved last year because of pressure and misinformation by the fossil fuel industry. And so I would be so interested in seeing and using eventually this dashboard, whether we find higher asthma rates near I-95. And a lot of it is not an exact science for sure, but it would be very interesting. Asthma, there are a lot of causes of asthma, so it's, again, look forward to any evaluation of that, but air quality is so important, especially in our urban center. We have both the Merritt Parkway and I-95, which has constant traffic jams, and that does affect people's respiratory health, I am sure. So I'm looking forward to seeing how this develops. Thank you very much for listening.
Thank you, Ms. Loricella. Do we have any other members from the public? Don't think so. Any other comments from the board before we adjourn today?
Keep up the good work.
Thank you, Ken. All right, it is 9:10, so we will adjourn. Have a good day, everybody.
Bye, thank you.